everyone in the room and also online to another mental health question time brought to you by the Mental Health Lancet Psychiatry and the UCL Division of Psychiatry. I'm Sonia Johnson from the Division of Psychiatry. My main qualification as a chair is that I'm very ruthless, particularly about timing, both speakers talking too long and questions that aren't really questions. My main qualifications for chairing this evening, apart from mainly ruthlessness, are that I work quite a bit on social connections, and I also have quite a strong belief that the world would be much, much better if everyone sang in a choir. So what I'll do is introduce each speaker and ask each of them a question which they'll talk for about 4 minutes on, or up to 4 minutes, doesn't have to be that long. They've been forewarned of those questions, and then after that we'll open it up to you for questions. And people who are listening online will also check in periodically with Andre for the questions and issues that are coming up online, as this is all being live tweeted and live streamed, and there'll also be a recording available afterwards. And don't forget the final part of the evening, which is drinks down the road at Gordon House. We'll have a couple of people for you to follow. It's just a couple of minutes away, and that'll be a chance to further discuss the issues of the evening. Okay, so first of all, it gives me great pleasure to introduce Niall Boyce, who's also one of the hosts of MHQT. Niall is the founding editor of Lancet Psychiatry. He's originally a psychiatrist, trained at Oxford University and on the UCL rotation. Among his many interests are suicide research, trauma and social aspects of mental health. And currently he's also working on a PhD in Renaissance culture at Birkbeck. And I'd like to ask him, what are the problems with publishing research evidence on culture and mental health?
Thank you very much, Sonia. Now, the first thing to say is I wholeheartedly support any attempt to get mental health care to widen its horizons and to widen the repertoire of treatments which are available, because on a very basic level, the more options that we have, the more likely that people who are experiencing mental health problems will be able to find a solution that's a good fit for them. But there are problems. So if culture is going to be prescribed on the NHS, it needs evidence. And my job as an editor is to evaluate and publish research, and I can say that this will present a challenge. For instance, the randomized controlled trial is still thought of as the gold standard of evidence, and RCTs are tricky in mental health at the best of times. And I think even more so if we're talking about the sorts of evidence which would be needed to provide culture on prescription. So we might ask, what control group are we going to have? How is treatment going to be standardized? Should it be standardized? And then, of course, the issue, which I think is the first and most important one, which is that of outcomes. Do we expect prescribed culture to work in the same way as prescribed medication or even prescribed psychotherapies? For example, I think of the Matisse trial of art therapy a few years ago, which was published by BMJ and was carried out by people here at UCL. And that was a considerable piece of work. It was a negative trial, but when I look again at that trial, I wonder if the choice of outcomes, which were the sorts of outcomes I'd expect to see in drug or psychotherapy trials, would really capture what people were getting from art therapy. The other thing I'd raise is that I don't think that this exchange can be a one-way street. And this is where the phrase arts on prescription or culture on prescription makes me a bit uncomfortable. I think that culture on prescription is a good thing, as long as it involves healthcare professionals respecting the power and the complexity of art, rather than simply operationalizing and co-opting it. So I'm worried, for example, when I hear this week that Bradford City Council has diverted some of its health budget to keep libraries open. This unintentionally sends the message that we value art only in as much as it provides a tangible function. So when Oscar Wilde said, "All art is quite useless," I think that this was less a comment on art and its value than an indictment of what society chooses to view as useful. So it's important that we, and by we I mean scientists and researchers and editors, nurture a really healthy respect for the arts and humanities and try to figure out how we can build collaborations in the clinic, in universities and in print. The arts and humanities are not just a nice extra, a nice coffee break before we go off and do other work. I hear a lot these days about the humanities being in crisis, and I've also been hearing for about the past 20 years about psychiatry being in crisis. And I wonder if we're actually talking about the same crisis, that these are different aspects of the same crisis. And it seems to me that in the past decade, both psychiatry and the humanities have been facing fundamental questions of value and of their values. So I wonder if humanities can provide meaning, which has been lacking very often from mental health science, and if mental health science can present new and interesting vistas to the humanities. So I think from a publishing point of view, culture on prescription has got a future, but it's only got a future if mental health science, care and publishing is willing to learn from the arts rather than simply subordinate it. Thank you.
Thank you very much. Very interesting and wonderfully timed. Okay. So next, Laura Fischer. I'm very pleased to welcome you to UCL. Laura is an artist, mental health activist and researcher whose particular focus is on trauma. In her postgraduate studies, she's worked on developing novel interventions to respond to violence and abuse. And she focuses particularly on the neurophysiology of developmental trauma and the use of creative body-based methods in this area. And her work has resulted in the award of an Improvement Leader Fellowship by the NIHR Clark. And Laura, the question I'd like to ask is, how could research support embedding creative approaches in mental health care?
So, yes, okay. So I think I'm going to actually lead to the research bit at the end and start with the two critical things that I think are important in what we have to gain in embedding creative approaches in mental health care. And the first one is that creative approaches can complement and complete other treatment approaches, meeting them at their limitations. And making for an integrative approach is holistic and can have much better outcomes and a much better and safer experience for people going through it. And I'll give an example of that from what I know best, which is trauma. Currently, the vast majority of accessible therapies on the NHS. Does it work now? Yes, it definitely works now. Can I just carry on, or do I want to start again for the virtual people?
Carry on, Liv.
Okay.
Is that right?
Time, yeah. Okay, so speaking from a trauma perspective, most accessible therapies on the NHS for adult survivors of childhood trauma, or any trauma survivor, are talk-based. And the challenge is that talk or words is not the language of trauma. Traumatic memories are registered non-linguistically in implicit memory predominantly, in body sensations and physical manifestations. So, and actually what's more is that the body and implicit memory have a greater influence on the mind and explicit memory than the other way around. So I'm not saying let's scrap talk-based therapies, but I am saying that we can make them we can improve them greatly by including non-verbal creative means for people to express, self-regulate and much more. The other point that is really important in embedding a creative approach in mental health care is that creativity or creative approach enables a shift of power dynamics. Traditionally, the patient is the receiver of care, which is a passive role. Is that really the best we can do? I'm not sure. A creative approach allows for the person to take leadership in their own healing process. Because creativity, no one but yourself owns it. And that's a really powerful thing. So if you use your creativity for your mental health, you unlock a breadth of possibilities that a strict treatment protocol will not offer. So, and my answer is actually quite short, because I had 3 minutes time, not more. So, to go back to the research points, the research can support support this not only by focusing more on this, which is quite evident, but by being reflective of this. So the first thing is, research itself as a process can embrace more creativity, which is challenging for a lot of academics to understand, because I think there's a division between science and art, and I don't particularly think it's a valuable distinction. There is a practical application to it, but creativity and science go hand in hand. So there is that, but there's also the fact that it's past the time for us to pat ourselves on the back because we've ticked the patient and public involvement box, PPI box. It's really past even the time to champion PPI. It's time for research to really question what it means to work with and to respect lived experience, and to even let ourselves be led by it. So research influences clinical practice and vice versa, and therefore we can't just think of the shifts in creative approach and the shifts in power dynamics in practice without thinking about reflecting those same shifts in research.
Thank you. Perfect. Thank you very much. So next, I'm very happy to welcome Lorna Collins, who's an artist, writer, journalist, researcher and campaigner, and also an expert by experience of mental illness treatment and recovery. She works with Time to Change and with Mind, campaigning to change stigma and discrimination against mental illness. And as an author, she writes articles for a number of newspapers and journals on these themes. And Lorna, I'd like to ask you, what's the role that the arts can have in the process of recovery from a mental illness? Thank you.
Okay, so this might be a bit lively, because I'm showing you some pictures. This is all about art and culture, apparently, and I want to show you my story. This is my story. So first of all, we set the scene. It's April 15th, 2000, and I have a very severe traumatic brain injury. I am unresponsive. I fall into a deep coma when I am revived. I won't go into much. Anyway, I go to hospital, obviously, and I awake eventually in some way, partially awake. I develop a number of psychiatric illnesses as the injured brain becomes an injured mind. I'm called treatment-resistant schizophrenic. I'm called borderline personality disorder. I'm called anorexia nervosa. I'm called many things. Okay, next slide. Change the scene. I am locked away in a psychiatric hospital. Many hospitals, about 30 or 40 hospitals, over the next 19 years. The rooms didn't look like this. They were much smaller than this, but there were cells, and I would compulsively create. I was silenced by my misery, but I could express the inexpressible by creating on paper, by writing, by drawing, by painting. People ignored this, but that's all I could do. Next slide. Until one day, a doctor looked at this painting, this picture. A wise doctor. He didn't last very long in the system. And he looked at this picture and he said, I can see you. I can see schizoaffective disorder in the tactile hallucination, the lubricated barbed wire that was asphyxiating me. You can see the mood disorder. I'm not a doctor. I'm just saying what he said. So he diagnosed me, and then he medicated me, and then he developed a treatment for me by looking at this picture. So art was prescribed as medicine. Next slide. They put art and painting on my list of medicines. So art was prescribed as medicine. Now, at this point, art kept me alive, just. There were huge, once again, problems in the system of healthcare and medicine. So I lived, in a way, I lived as a revolving door patient. But I was alive because I could express what I was experiencing. Next slide. And then change the scene 15 years later, or 16 or 17 years later, I was admitted to a ward in Oxford, where suddenly I found a treatment programme that was individualised for me and established and built around my art and creativity. And then, and art and creativity enabled me to go through the horrible, miserable, desperate process of recovery. And it's enabled me to have a renaissance and invent my new well identity.
Wonderful, thank you very much. So next I'm very pleased to introduce David O'Flynn, who's a consultant rehabilitation psychiatrist across the river in South London and Maudsley. He's worked for the last 3 decades with people living with enduring psychosis, and he has a long-standing interest in art and mental health, and is currently chair of the Bethlehem Gallery and also of the Adamson Collection, which is a mid-20th century asylum art collection, which currently he's securing in collaboration with the Wellcome Collection. So David, I'd like to ask you, what can the arts achieve that other mental health approaches do not?
Thank you. Thanks everyone for coming. It's a great audience and it's been a great discussion. I think I was on the fence about the premise about prescribing art, but let's see where we get by the end of the evening. So I'm a clinician. My only experience of using art was my own analysis for most of the late 80s. And the art materials terrified me. They sat in the corner of the room for about 2 years before I could finally approach them. So I mentioned that just on my background. My first real setting was art projects in the early 90s, part of a big program doing about employment and schizophrenia. And we're there interested in using art to help with the economic exclusion of those psychosis. So the idea is if you can make some art, sell some art, maybe you can make some income. And that still means relevant for Bethlehem Gallery, for example, where our commercial branch is important. And it matters to people if their work is bought, and if they can become a patient, not an artist, not a patient. It's important. It's not economically viable because benefit rules prevent you making any money. It certainly started my interest in these small and medium-sized community projects. A lot of the art delivery in the UK at the moment is in these small community projects. And they're scattered across the country. They tend to evolve locally. They go from grant to grant. The ones I work with at the moment at the Bethlehem Gallery, Dragon Cafe, which is a progressive day's resource in Southwark, and Raw Sounds, which is a urban music project in Brixton. So, on the other bit is the Adamson Collection. I'll come back to the other bit. So, the Adamson Collection, Adamson was an artist who established art studio in asylums, was a major leader in the reiteration of art and mental health after the war. And his work led on to art therapy in many ways. So from him I've really learned that art does heal, art helps people, in his language heals. So that art does allow you to do things and find things of yourself you wouldn't otherwise find. A lot of the work is now what we call outsider art, art that's outside the mainstream marginalised art. I want to talk about that later. My beef is that I don't think you can prescribe these things. And certainly the Raw Sounds and Bethlehem Gallery, we survive financially for funding the collective artistic output of the project. So that's only like if you took 2 years to start some work, it would be absorbed. We have somebody referred to the Dragon Cafe by GP. He wanted art class, he wanted results in 6 weeks. So I don't know what results he wants in 6 weeks. Does he want a painting? Does he want some changes in measures? The idea of it becoming a prescribed output-driven treatment bothers me. Thank you.
Thank you very much. Wonderful, thank you. These people are such good timekeepers. I'm so happy. So, next, it gives me pleasure to introduce a colleague from the Division of Psychiatry. So Aaron Candola is a PhD candidate in our division. He researches the relationship between physical activity and fitness in depression and anxiety, and has just published an important Lancet Psychiatry paper on this topic, and his master's degree and his previous work in an Australian neuroscience lab also focused on the influence of exercise on the brain. And Aaron, my question for you is, what is the current evidence that physical activity is important to mental health?
Thank you, Sonia. This is going to be the odd one out, I think, based on the other questions. So I'm sure everyone's sick of hearing how good exercise is for you, but that's exactly what I'm going to talk about in the next few minutes. Physical activity has been associated for years with a range of different health benefits, and it really has a profound impact on our bodies and our brains. So it's no surprise in the last couple of decades there's been an upsurge in research showing that these benefits also extend to mental health. There has been numerous clinical trials now showing that physical activity interventions can help reduce the symptoms of people with depression, anxiety disorders, post-traumatic stress disorders, and although there are fewer clinical trials in this area, there is some evidence that it might be helpful for people with schizophrenia as well. And a really important feature of these trials is that beyond treating the symptoms themselves, these frequently people are reporting a lot of other benefits that are not associated with the symptoms necessarily. So things like improvements in quality of life, improvements in sleep, reductions in stress, improvements in confidence and self-esteem. And importantly, people are reporting these sorts of benefits regardless of whether their symptoms have changed as a result of the intervention itself. A more obvious feature of the interventions is they also improve the physical health of the participants in these studies. And this is particularly important because people with long-standing mental health conditions are often at a higher risk over time of physical health problems. So these trials are a really strong source of evidence for the use of physical activity in the treatment of mental health, be it alongside more traditional forms of treatment such as talking therapies or even as an alternative in some cases. There's also been a lot of interest in using physical activity to try and prevent conditions such as depression and anxiety disorders. And there's been a growing evidence base from studies that essentially take large groups of people from the general population, and they follow them over time and track various different things, including their activity. And what these have shown is that the more engagement with physical activity of any kind and higher fitness levels, and also less time spent sitting down per day, are all associated with a lower risk of depression and anxiety disorders. So people with and without a mental health diagnosis, there is good evidence to suggest that physical activity can improve mental health. It also has a range of other benefits, and it certainly justifies its use in mental health treatment as a relatively low risk and low cost approach to tackling the mental health burden.
Thank you very much. So finally, very pleased to introduce UCL colleague Daisy Fancourt, who's increasingly well known for her work on the effects of social, cultural and community engagement on health, and particularly mental health. And Daisy's an associate professor of psychobiology and epidemiology and a Wellcome Research Fellow at UCL. She's also a consultant to the WHO on arts and health, and she leads the March Mental Health Research Network, which is currently bringing together over 1,200 researchers and community organisations to focus on community assets and mental health. And Daisy, my question for you, and other people have been so good, I might even give you an extra minute, is whether it's realistic to think that the arts and leisure activities could become part of what's routinely offered on the NHS, and if so, what research can do towards that aim?
Thank you, Sonia. So in one sense, this question is pretty easy to answer, in that yes, it's realistic, because it's already happening. And this has been something that's been bubbling away for the last decade or so in different parts of the country, with different clinicians working alongside community organisations to refer individuals through to different cultural activities in the community. But as of January last year, NHS England has announced a major investment in this as part of social prescribing. So we've now got around 1,000 link workers whose job it is to be based within GP practices and primary care to help signpost and refer people on to community activities if it's felt that this could benefit them. And the aim is to have around 1 million people a year going through this scheme by 2023. So in that sense, this is happening. And a lot of the logic behind this comes from the idea that arts and cultural activities, not just in terms of the medical therapies we've heard mentioned already, but in terms of leisure activities, can have intrinsic benefits for people's health by bringing together lots of things we know are good for health, like social engagement, physical activity, emotional regulation, and therefore triggering different causal mechanisms that can link in with mental and physical health outcomes. But the question is, should this be happening? And I think there are 3 key things to think about here. The first of these is patient needs, and actually we do know that patients are increasingly facing complex health problems that combine psychological and physical health components. And we know that lots of these individuals are not receiving care that's providing for all of their needs. And this is evidenced by the fact that around 30 to 50% of GP visits are actually not for medical but for social reasons at the moment. And we know from patient reports as well that they feel the need for additional support. So from that sense, this perhaps should be happening because there is a patient demand for extra support. The second issue is around access. In an ideal situation, everybody would have equal access to the arts and would engage equally, which would mean that everyone had equal opportunities to benefit. Whereas we actually know there's a pretty major social gradient across arts participation, and it's a very similar social gradient to the one we see across health, which means that those individuals who could benefit most tend to engage least. So social prescribing as a mechanism can help to actually link those individuals who might be lower levels of socioeconomic position and more health problems with cultural activities that could benefit them. And I've been analysing real-time NHS electronic patient record data with NHS England, and we're finding that in fact there is evidence that the people who are getting arts on prescription since August are actually those who should be getting it, i.e. those who wouldn't normally be accessing. But then a third issue is around, is this going to benefit the health sector? So there's a particular hypothesis here that if we have arts on prescription, we're going to have fewer people using healthcare services, therefore it's going to save money for the health sector and overall be a benefit. But this is the most complex one, because actually it's quite plausible that because of referring people to the arts, they're actually going to use health more, because they might have higher levels of activation. Now this won't necessarily be bad, it could mean they're going for health earlier on, and therefore we're catching problems before they become bigger and more expensive. But it means the analyses of this are going to be very complex. And it's going to take us quite a while to have the right data to be able to look at this and be able to look at it with enough nuance. So in terms of research, I think this is a really core priority. But because we're not going to have the answers on that for a while, I think overall in answering this question, we really have to sort of blow the doors wide open and think about the much larger conceptual and theoretical issue about what kind of healthcare do we want to be delivering. How much do we actually care about prevention and promotion and therefore want to promote things like arts and culture as part of that? How much do we actually think it's the role of health to look at these social and community factors other than just biomedical factors? And how much do we actually want to have cross-sectoral working that will be linking health with these other domains? Thank you.
Thank you. Brilliant. Thank you very much. Just to forewarn the speakers, I will be asking you at the end, optionally, to answer the question about what you think is the research question that you'd most like to see addressed next and by whom. So I'll ask you if you'd like to answer that question when we get to the end of the discussion. Okay, so we've got 2 active roving microphones. Brilliant. So for the benefit of the audience online, please don't talk until the microphone reaches you. So who would like to ask a question for our panel? Right up there at the top.
Hi there, thank you for putting the event on. It's been really insightful so far.
Would you like actually to just briefly introduce yourself, if you don't mind? Thanks.
Yeah, my name's Kiz. I set up a project called Hip Hop Heals, which deals with trauma, grief, bereavement, mental health disorders, but by combining hip hop with poetry therapy techniques. And I want to set up a hip hop therapy style program on social prescription. I've been exploring research in this field, and there's nothing like it in the UK at the moment, but I'm coming up with constant barriers. I'm somebody with lived experience, and the language of research is isolating. I've engaged in research, so I'm okay, but I'm thinking about other lay people that want to set up arts on prescription schemes that might not have the education or the access that I have. So when I went to look up the new Social Prescription Academy, it was £3,000 for a course. So my question's around allowing the layperson an opportunity to create their own programs. I know we're early stages, it's not being developed and rolled out across the country, but yeah, how do we make it accessible for everybody?
Laura or Lorna, would you like anything you'd like to say?
I think we need to attack this from multiple angles. We need to work on top level and from top down and bottom up. So I mean, we need to talk to people like Daisy, who has lots of power and influence. It's true. And she's doing great things in talking to the important people. So we need to access that facility, but also translate it and enable it to be possible to integrate from the bottom upwards as well as the top down. So I would ask Daisy, how do we do that?
Okay. I was going to ask Daisy as well.
Thank you, Lorna, as co-chair. I think the main thing is to realise that you're not alone in facing that, and perhaps to link in with existing networks. So, for example, the Culture, Health and Wellbeing Alliance, which contains thousands of individuals and organisations who are in similar positions, therefore you can have peer support. We're also trying to develop more resources, for example, through the March network. So if you want to join that, again, we try to make sure we link people up, but also crucially linking organisations with researchers as well. And this is probably going to sound like a shameless plug, but I also wrote a book for community organisations on how to do this called Arts and Health. So that might be supported as well.
Yeah, just to say, I'm a member on the steering board for the March, for the Lens, through the Culture, Health and Wellbeing thing. It's just good to bring down, isn't it?
Yeah, great. Okay, great. Thank you. Yeah.
So I'll just add, I mentioned before how important it is to include lived experience in research. And language is one of those really important things, because research research is not very accessible, as you said, and it's usually published in great journals, but that are not accessible to everybody. So I'm currently coordinating public involvement on the public mental health research program for England, and we have a team of people with lived experience in mental health. And basically what we do is then stand up and say, hey, don't say this, we have to think about it differently, use different words, and we constantly try to challenge. And to be honest, a lot, to their credit, most, at least a big chunk of academics are really open to changing things and making things more accessible. But it does take people who are outside of that realm to come and actually work together. And so yeah, I back to what Lorna was saying, I think it's up and down, and I mean, actually, because I don't believe in hierarchies, it wouldn't be top to bottom down, but working together probably is the key in disseminating research outputs in other means than just academic papers, and not just relying on simple lay summaries. And to do that, what best way to do it than to include people who actually know what we're talking about in that research, people who live it. And for people outside to really step up and say, and to try and hit the door and bring it open, because we've got to, there to do that, I guess.
Okay. Down here.
Hello, I'm Marianne. I've got lived experience because I have post-traumatic stress. It's associated with physical health treatment and treatment by medics who have done wonderfully for me, but have also traumatized me. I just wonder how we define, when we start a research project, how are we going to define what I know for me, my world is different from someone else's world, and I've got bone disease. I have had lots of practice. I will continue to have lots of practice, and I find doctors often find that very hard to accept that they're not going to succeed in stopping me having future practice. So perhaps the element of well-being, improving well-being despite the practice is this way.
My experience of wellness and recovery changed a lot over the years, and I've come to accept and understand that wellness for me is something entirely new. I'm not the person who I was all those years ago. I have to commit to my recovery every day, but it's rewarding in the end. And for me, wellness is something I strive towards and feel happy with when I touch it from time to time. It's individual, it changes, it's a journey.
I also think, Mary, that you've hit on something very important there, which is that there's maybe something within the arts and culture and creativity that doctors could learn. And when it comes to the arts, I see a lot these days about role models, and I'm never sure about this concept of role models. What I think the arts do is really present people with a great sense of possibility and an idea of how things can be different, and that sense of the meaning that individuals make of things. And that's where I think that it speaks to the point which I was making earlier, which is that this has to go both ways. It can't just be doctors grabbing arts and putting them out in prescription, but they've also got to be open to learning as well from the experience.
I was just going to add something which actually Lorna's reminded me of, which you do every time I hear you speak, so it's always very powerful. Yes, which is around the fact that there is an evolution in terms of what matters at different times. And I had a lovely phrase a few months ago which was saying that it's not always what's the matter, it's what matters. And therefore, perhaps there needs to be a shift within medicine, not to thinking that people have got problems that they need to fix, but thinking what does that person want from their life and what's important to them. And I think from the research perspective, which you asked about, I think what's really important then is making sure we look at multiple different outcomes. So we're not just suggesting that a change in one marker is proof that something has therefore been a success, but that we're looking at a whole range of different aspects that happen to different aspects of people's lives.
The best thing the doctor has ever said to me, which was the first time I ever heard this, was when I was 22 after a long time in mental health institutions in care of orthopaedics. And he held my arm. It was a proper elbow doctor, which I found very hilarious that there was someone who specialises in an elbow. But he held my elbow and he looked me in the eyes and he said, "How is this elbow affecting you?" And there was nothing that doctor could do for the elbow. It's still as it is. But that is the most healing thing anyone has ever said to me, and I just burst into tears and that was the beginning of me starting to understand a lot more about myself. And I think that's something that how is it affecting the patient is quite a, not how does it look, but how is it affecting?
Okay. Yeah, here in the middle.
Hi, my name's Rhiannon. I think in the NHS we've become, I'm a GP, a bit obsessed by outcomes, which may be good, may be bad. And I just wondered if we were going to be prescribing arts as treatments, what were good outcomes to measure?
Good question.
Because I'm being asked, the person who probably doesn't agree with outcome measures. Personally, I find the idea of the GP wanting an outcome from a Dragon Cafe within 6 weeks of painting lessons. I don't know what outcomes he wanted. Does he want a depression and anxiety score to change? Or does he want a picture of himself, a flattering picture of himself sent back? I think it's okay. I'm personally more interested in how we think about non-biomedical understanding art-based outcomes of these activities, because it's often the making of the object that wouldn't have existed otherwise, the film, the painting. I think that my patients, when they do raps of the raw sounds, the anger, the beauty, seeing them diverting that anger not to objects but to music is great. You don't capture that in an outcome measure, I don't think. But if it's going to be prescribed treatments, I guess we do need to medicalise it. But I do think we're throwing the baby out the bathwater personally. That's my point of view. Dave might have to come back on that.
Does anyone want to speak in defence of outcome measures? Either panel or audience?
I frightened you all.
I think it's a very tough line because on the one hand we don't want to somehow imply that arts and culture are somehow exceptional and therefore don't need to apply by the rules of normal medical treatments and therefore we haven't got to bother with gold standard research approaches or particular outcomes. But at the same time, it's what we've just been mentioning about that we have plurality of outcomes and look at things beyond a single measure and look at things beyond the obvious measures as well. So I don't really have an answer for that other than the fact that I think we particularly need research that combines different methodological approaches. So particularly I like things like the Medical Research Council's guidelines for complex intervention research because they encourage a combination of quantitative and qualitative data that combine gold standard trial designs but with other approaches nested within them that mean we can look at this from lots of different lenses at once.
Anything from Twitter, Andre? Has anyone got a question?
No specific questions, mate.
No. Okay. Yeah.
Research associates in Oxford and as well as the Arlington Institute, just down the road. I just want to ask a broad question. In terms of using arts and sports to help people with mental health, so what is the role of technology here, digital technology, positively and negatively?
I went to, this is a bit of a plug, but it's not my thing, but I'm still plugging them. I went to a roundtable discussion of 64 million artists last week or the week before, and they engaged with digital media to present an artistic approach that helps people with minor, they call it minor, mental health issues such as anxiety and depression. And their approach is to use things like WhatsApp and social media platforms to present creative exercises. So they send text messages saying, do this or do that. And the participants are who take part in this, do those exercises, connect with all the group of participants, and feel better, they say, by doing these exercises. It might be take a photograph of a tree, or collect 4 leaves and make a pattern, or something like that. So they do that, they take a photograph of it, put it on social media, and they get support from that group, and then they say that that really helps their mental health. So that's just an example of sort of digital media being used to initiate a sort of creative exercise and support mental well-being. So it's very successful, it's worth looking at.
Other thoughts? No?
Yeah, I think that digital is important. I think that one of the things which it can do well is to link people and build communities. Now, at the moment, I think that the particular models we have for digital communities are pretty bad because they're based around certain algorithms which seem to sort of drive division and polarization. But I'm more of an optimist. I think that there are ways in which people can find a meaningful connection online. And interestingly, this is, just to bring Aaron in, one of the things which we published a while back was Adam Chekwood's paper on exercise and mental health. And I don't want to overstate the strength of the evidence, but one of the things which seemed to be showing up there was that team sport participation in particular seemed to be associated with better mental health. I can, of course, make a comment as to the direction of causality, but I wonder if maybe to broaden the discussion a bit, when we're talking about the benefit which exercise has on mental health, that some of this is that exercises for many people are rooted into a community. And I think that when we're talking about anything from digital to sport, we always have to think of how this is a route into a community of common and diverse experience, which I think can be a very helpful thing in itself.
Yeah, no, I agree. I think that there's definitely something to team sports that could be beneficial to mental health, but I think getting to the point where you want to play and engage in a team sport might be quite a difficult step that a lot of people might not want to make, particularly if you're experiencing symptoms that might counteract your desire to go and hang around with other people and do something you might not be confident doing. But to return to the digital technology question, I think there are good sides and downsides. Certainly in terms of increasing physical activity in general, digital technology has been quite a force recently, and they're now used increasingly in research to try to not just track how much activity people are doing, but to encourage through little nudges. I've got a Fitbit on right now, and it tells you when you've not been moving for an extended period of time. It also tells you your steps, you have targets. These things to some people don't mean anything, and you ignore it, you turn all the notifications off. To other people, it's very encouraging, and it helps them to. Sometimes you don't realise how long you've been sat down for. I mean, I certainly don't. Sometimes I can sit down for hours, and I don't realise until my Fitbit tells me that I've been sat down for ages, and I just get up, go for a little walk around the office, and go downstairs, get a drink. Little things like that can really help to increase your activity throughout the day, and digital technology has been a big part of that.
Realising that MHQT will trigger everyone's Fitbit into saying they've been sitting down for too long. We'll think about what to do about that in future. In the middle.
Thank you, Philip Davis, interesting in benefits of reading literature. Dissatisfied, apologies, about the discussion of outcomes. I went to a seminar where in relation to prisons and secure units, somebody from criminal justice personality disorder unit was saying, rightly I think, that instead of thinking about outcomes, you wanted to think about identifying when good things happen and making sure, as far as you can, that they can happen again. But in order not to seem wishy-washy and to have funding, we have to have a more robust account of, philosophically, that changes the nature of outcomes, as you were saying, they are not appropriate in some cases, and the methodology that can measure them. There is an educative and public duty here, and it won't do to say, I'm not too sure how outcomes. So I want to put that question back to you, because it's not a good answer at the moment.
Can I just add to that?
Yeah.
I agree with you. I think the notion, I'm being a philosopher now suddenly, the notion of outcomes is tautological and teleological. So when we mean it's an end goal and it's fixed. So I suggest we change the philosophy of the notion of outcomes and create a different vista. How do we do that?
Good. That was the question I wanted.
Yeah.
Sorry. So a project we've been running as part of the Mental Network that you mentioned earlier is we've been trying to identify all the different things that different types of leisure engagement, so arts and culture, but also more broad activities can affect. And the way we've been trying to conceptualise this is the mechanisms of action. So what happens as a result of people doing leisure. So this paper is hopefully going under review in the next week, so I'm sick to death of it. But we so far identified around 600 different outcomes, which we split into different psychological, biological, social and behavioural processes. But we're particularly saying here that we can't just look at these in terms of a long list of outcomes. We presented them as dozens of pages of tables, and one of my PhD students, Henry, is in the audience as well, who's spent a huge amount of time cataloging these mechanisms with me. But we particularly say we have to think about this in terms of a slightly different framework, which is complex adaptive systems. So we have to recognise that arts activities are complex, they've got a lot of components, but the way they affect things isn't necessarily static. It changes a lot over time. And the processes that are changed, so the mechanisms that are activated, intersect with one another. So it could be that engaging your local choir starts to initially affect certain psychological processes that will then trigger other biological or behavioural processes that will then feed back. And it's also possible that those processes will be what we call autocatalytic. They'll loop backgrounds and affect the amount of leisure or arts that people are doing in the first place. So it can become a kind of positive feedback loop. And it's possible that all of these things will affect health, which will then, like particular health outcomes, the traditional outcomes we talk about, that will then affect people's engagement in the first place and bidirectionally affect the mechanism. So what we're saying is that we actually have to conceptualise this a bit differently, not just talk about it being this linear process from arts to outcomes, but seeing it very much as a circular process that's multi-layered, not just looking at individual outcomes, but also at group level outcomes. So for example, saying that arts might reduce loneliness at an individual level, but at a group level, they also might be doing things like affecting social cohesion within communities that mean that loneliness is less likely to happen in the first place. So we have to consider it, in this sense, from a kind of 3D, multi-directional, very complex approach. So hopefully this paper will be out later in the year, which will give more detail on it. But I think I agree that the outcomes is problematic and complex, but I feel like we are making progress theoretically with it.
Yeah, it's really, really difficult. I think that if I were to think where a possible outcome might come from, I think it would be from the experience of change. Because while it's very hard to generalize about mental health problems, in that everyone has their own unique experience, the one experience that I hear coming up time and time again is a sort of entrapment. Whether it's depression or psychosis or trauma, there's a sense of entrapment and enclosure. And what people describe to us, perhaps, and this applies to what you said, Lorna, is that sense of the moment that something changes, that there's a sense of movement and being able to get beyond that entrapment. Now, quite how you operationalize that or measure it, I'm not sure, but I suspect that a measurable outcome might come from that subjective sensation.
I mean, I think it all comes down to what you were saying, what does it mean to be well? And often the clinical or scientific definition is not the same as the person experiencing it. So I think if we're going to think philosophically or practically about outcomes, it has to start from that definition of being well and who has the authority of saying what that means. And I think we too often put a dichotomy of being well versus unwell, or healthy versus unhealthy, whereas actually for a lot of people, we have mental health difficulties and challenges that we are going to live with our entire life. So if we keep just measuring before and after, is there improving symptoms, it's not always going to be appropriate. Often a better question is, how do we live well with our mental health, irrespective of whether the symptoms change?
Up at the back. Introduce yourself.
I'm Danush. I'm at Wellington County Grammar School's lower six. So one thing that really caught my attention was that, as you said, Lorna, art helps you find yourself. So it's something that builds your character. However, I know from a young person's point of view that it's sort of neglected in our education system. So for example, I did a music GCSE, and it was almost like laughed at to actually do a music GCSE, even though it's a performing art, and it didn't actually help me in terms of building my character. But it's also international as well. So I was in India until year 7, and even then, even in that education system, there wasn't much importance given into the arts being done. There's mainly like science, maths, English, and others. But what do you think could change? Because obviously it's very important for a young person's mental health to find themselves by the arts. So what do you think could change perhaps the education system, or perhaps how the school can find to actually implement arts into finding personalities and character?
Okay. Who would like to pick that up?
I think you've raised a really fantastic point there, and it's really nice to hear that coming from a young person as well, because actually I haven't heard a lot of young people in school saying that they really want these things, so it's lovely to hear that view. I've been working with the Department for Education over the last year. We've been talking to them about some of the evidence base, And certainly a few years ago, there was a big push on arts within schools because it was particularly thought it might help things like academic attainment. That's arguments which have gone down a bit and there's not been as much interest in that side of it. But I think there is growing interest around arts and mental health, therefore the importance of arts within schools for mental health. I think the slight problem there is that it always feels like there has to be a reason to have the arts in schools. There's a concern that if we have it, it's somehow going to take away vital time from other subjects. Whereas actually, we know that arts in school is important just for encouraging people to develop skills so they can go and work in the creative industries, which is one of our biggest industries in the UK, but also that there is a link between people's engagement with arts and their academic attainments. So I think that the literature suggests that there could be benefits for mental health within schools, but I think the question is how do we convince people, or how do we make the argument that it's therefore important that they're included? And I think possibly, it's, as well as research being important here, maybe there's an opportunity for young people like yourself to actually use your voice to say that you would like more of this because you feel like it could be of value for you too.
What else? Yeah. Great.
Hi, thank you. John McMahon from Arts Council England, here with my colleague Richard from the Arts Council as well. Try and compress this because there's so much to kind of respond to. I had a really interesting meeting yesterday with one of my counterparts at Natural England. We met primarily to talk about social prescribing. The discussion broadened out, so we were thinking about how this sort of relatively sort of linear system that's building around social prescribing, there's about specific targeted healthcare interventions, plays into helping to rebuild a vibrant, accessible, dynamic ecology, social infrastructure, back online, rebuild the social infrastructure that contributes to a life well lived, to strong and healthy communities. And those two things are, a conjoined goal in a way. If we get social prescribing right, we can re-engineer, reintegrate and render accessible our social fabric in a new way. Just interested, and that feeds into building a culture of well-being, a culture of health promotion. It isn't about people going to the doctors, it's about people understanding this is how I care for my well-being through accessing nature or participating in sport or the arts, irrespective of my wellness, physical or mental wellness in other regards. Just kind of interested to hear your perspectives on building that social ecology, I suppose.
That's very interesting. I don't have any authority to make an intelligent comment. I'm just saying it sounds quite like a panopticon, that approach, the idea that social prescribing becomes embedded in society, so that people don't have to access help because they already are enclosed within the idea of healthcare in themselves. Does that make any sense?
Yeah,
is that what you're saying?
Without the negative connotations of the panopticon. Yeah, absolutely. Yeah.
But can you see that it is in some senses brilliant and wonderful and exciting and healthy, but in another sense it is also seen enclosing and slightly autocratic, but not necessarily. Sorry, I'm
against that neoliberal danger of the responsibility being placed solely back on the individual and the health system abdicating its responsibility.
Yeah. So how do you traverse that conflicting, problematic terrain then? How would we go about making a good thing or a bad thing? I don't know.
Yeah. How to avoid social prescribing being sort of pointless little packages?
They were autocratic.
Prescribed. Yeah.
I think I'm making a
problem. I have your question right. Are you implying that social prescribing is going to create this new world of art projects? Because there's a wonderful, vibrant sector out there of community projects exist already. And I think they generally feel left out of social prescribing debate. Almost like a new industry is being created around them. We don't think it's a shame. we saw with CBT, with the mindfulness, we create mental health industries that maybe don't then deliver all we wanted them to do. So more questions back here than answers. Do you want the microphone before you feedback?
Do you want to hand back the microphone?
We're going to move to my microphone.
Yeah, so it's about how they feed into each other. Obviously, the Arts Council, we fund a lot of that activity anyway that is non-healthcare facing. But yeah, I'm interested in the kind of complementarity and the mutual strengthening.
I guess my caution is to go slowish, because the CBT invention was quite a story to tell. There was a psychological treatment that got widely disseminated, and basically we treated really to its rightful place in the world. The activists will not agree with me there.
Maybe they haven't come. I don't know. Any other thoughts on that important point? Yeah.
Thanks. I think it's also about maybe learning to nurture a society which really values the arts. And this brings us back to the last question, which is that much as, clearly as the editor of a medical journal, I like STM subjects, but they're not the be-all and end-all. And we've got to recognise the value of the arts as, I think that in this country there's maybe a tendency to see the arts as being a bit suspect, a bit soft, a bit pretentious. I don't have any problem with pretentious. We don't have pretentious things. We wanted David Bowie, so I'm all for pretentious. But I think that there's an element in which the rise of teaching coding in schools, the digital technology at the expense of culture has I think been quite disastrous, and we need to reclaim a lot of ground for the arts and to really stress their value, and not value simply in operationalised terms, but in terms of creating a community and creating a culture, which I think is the sense that so many people are missing at the moment. I think we all feel we're in these individual pods and groups, and we're lacking cohesion, which the arts can bring.
Okay. We're getting towards the end. Hannah, do you have a question? Yeah.
Just advance with the microphone online. Daisy mentioned that there's a question for the whole panel really. There's quite a strong social gradient in arts, so how do we make sure that any kind of arts-based initiatives reach not only, say, university students, but reach everyone that we want to reach, particularly the people that might benefit from it the most?
Who would like to start?
I love this question because we've been looking at it in our research team over the last few months, and we've got a new programme of work on this. So we've had papers previously that have suggested that certain factors increase or decrease the likelihood that someone's going to engage in that. So, for example, we find that people who are high levels of educational wealth are more likely to engage. But that doesn't really tell us why that's happening. So if we want to address that, we need to understand not just the what, but also the why. So we've been using behaviour change approaches to particularly looking at psychological and physical capabilities, as in, are there actual issues that people perhaps don't feel like there is adequate access, for example, to different arts venues? Is this a case around psychological capabilities? They don't feel they're somehow educated well enough to be able to enjoy these things. They seem too high up. We've also been looking at the opportunities, so whether there are enough opportunities within communities for people to engage in, and we're particularly finding there are obviously geographical differences, but also around social opportunities, so whether people might feel stigma, for example, around engaging, or feel they're not welcome, or it's not culturally relevant or normal for them to do so. And then also looking at motivations, so automatic motivations, whether people do these things because they just, in the same way we all brush our teeth each day, do we sort of think this is something we should be doing without even thinking about it? But then also the reflective motivations, so do we understand the benefits for us, therefore do we turn to these activities when we feel we might need them? Do we feel that there actually is a value to doing them for our own skill development or employability or whatever? So we're gradually starting to map these factors, as part of the March Mental Health Network. And then what we're trying to do is then map these barriers onto behaviour change techniques that we could start piloting to try and increase people's engagement. So we're taking this from a scientific perspective, but actually we also know that a lot of community arts organisations are incredibly intuitive about what their audiences respond well to. So we're doing some fantastic access and outreach programmes, deliberately trying to engage more people. But I think it's always going to be something that's challenging because as audiences evolve, you have to keep adapting your approaches to make sure that you're continuously reaching those who haven't so far been engaged?
I don't know how we're going to make sure that GPs, the key prescribers, I guess, in this, are going to have a wide enough knowledge of what's available, what's culturally relevant. I don't know how we do that. Well, GP in the audience. There's a lot of knowledge for GP to have to know this is what will be right for you, because obviously classing is not everybody's taste, I guess.
Well, I think this is a really important question, and I don't have the whole answer at all. But my tiny contribution to this is that on my work on trauma, I think it's important to recognize both the fact that the neurobiological underpinnings of trauma are sort of cut across everybody and are common for the most part. And then the individual experience of trauma is unique. And I think it's important that we A, recognize that the commonality and the uniqueness, and B, that therefore informs how we reach people to both sort of emphasize that commonality and approach the uniqueness, which is a tricky thing to do. And I don't know if I do it right at all, but at least I try. And I do workshops for self-referred trauma survivors, whether or not they have a diagnosis. And I try to speak about it without being already restrictive in my terms. And I also try to think of all the details of location and space and whether they're everything. I try to think of every aspect, and obviously I will forget some, but there is something in there that is working in the sense that every time I run workshops, there are a huge diversity of people in terms of age, in terms of background, in terms of physical ability, in terms of whatever tick box you want to put. And so, like I said, I really don't have the answer, but I think if we recognize that we both have those commonalities and both have these differences and cater for both, however complex that is, then it leads us somewhere along that path.
Okay, we're very much out of time, so I'm just going to ask the panellists, and they can decline if they wish, but I hope they won't, to tell us finally what research question in this area they'd most like to see addressed and by whom. Now.
I think the most important research question right now is this question of outcomes. And I think that we've got to figure out exactly what we're expecting to happen, what value people are getting from art, and if art is and culture is going to be prescribed on the NHS, we've got to figure out a way to harmonise the language so that the people who are making policy, the people who are publishing journals, the researchers, people with lived experience are all on the same page, and that I think is a huge challenge.
So I think it's not a specific question, but the elements that should be considered are, I think you word it so well, sorry I keep referring to it, but what does it mean to be well, so it relates again to the outcomes. But also, back to the power dynamics I discussed, I think it's really important that we just break those hierarchies down and we recognize that for someone to live well with their mental health, to heal, whatever we want to call it, they need to have an active role in there. So they need to have a say as to what we're doing, and the arts can enable that, and how it can enable that, and how we can reframe those power dynamics and leadership through arts would be what I would be most interested in.
3 words, I haven't thought of the third one yet. Access, hope, and inclusivity.
It's hard to add much to what the audience has said and what my colleague has said. I guess it will also be good to include things like outsider art, the spontaneous art made by people with mental health problems that won't be part of self-prescribing. Work done in private, work done secretly, work done to survive psychologically, so that should be part of the view, I guess, when we talk about this subject.
As I alluded to earlier, there's a big problem in physical activity was how do we actually get people to do it. So I would like someone to come along and give us a perfect answer that would apply to absolutely everyone. How do we motivate everyone to just be more active in general?
I agree with everything that's already been said. I guess I probably just add to it, not another question, but more our approach. And I think we need to be anti-silo. So we need to have research that's cross-methods, cross-disciplinary, which is bringing together arts and also other kinds of activities, whether that's leisure or social or sports. And finally, a research that's connecting researchers with and involving people with lived experience and community organisations and key stakeholders right from the start, as opposed to these being things that happen after a paper has been published.
Brilliant. So I'd like to thank very much our panels who've made, our panellists, for such kind of resonant and interesting contributions. I think have given us all a lot to think about, and thank you all very much for your attention and your interesting questions. Please do follow Hannah.
Christina will be pointing people to the drinks menu from the entrance.
Okay, and if you get lost, it is at Gordon House, which is what, the white building further down the road?
Yeah, it's on the opposite end of the road, just past the chemistry department.
Okay. Right, okay. Going away from Euston, follow Christina. Okay, thank you very much for coming.